All right, so welcome, Dr. Imam, to the show. It's awesome to have you on here. Obviously, you are a weight loss doctor based out of Dallas, Texas. Why don't you give me a brief introduction about yourself and what you do and where your practice is located, and then we'll get into all the weight loss stuff.
Yeah, sure. So I'm a board certified in three specialties: internal medicine, obesity medicine, and allergy, asthma, and immunology. I work pretty much like half my time in allergy, asthma, and immunology, which essentially means like treating allergic diseases and desensitizing them and treating respiratory illnesses and things like that related to allergies and overactivity of the immune system. And then I have other interest in obesity medicine, for which I work around the other half of the time. I've been doing obesity medicine for about 5 years. So even prior to the GLP-1s being kind of mainstream and more popular. And before that, I was a personal trainer. Did that throughout undergrad, so familiar with like the bodybuilding world, I guess, in that sense. And mixed martial artist, so did a lot of Brazilian jiu-jitsu, jeet kune, boxing, all that good stuff as well. So kind of really, really got into like the Joe Rogan crowd for a while as well. So kind of a mix of all that. So yeah,
Where's your office located?
so we have two locations. The second location just got opened up, but we have one in what's Irving, which is a closer to downtown Dallas, and then one in Arlington, which is going to be where the FIFA World Cup finals are going to be next FIFA. So,
Oh,
and
wow.
yeah, right next to the Ranger Stadium. They just won the World Series.
That's pretty awesome. So that's kind of cool to know because I'm also a certified personal trainer and I'm like super into weight loss and obviously the I've been doing it longer and when I started we didn't have any GLP-1s, we didn't have anything. We just had all the old diethylpropion, phentermine. Byetta came out, but it wasn't quote unquote a weight loss drug. It was the
Mhm.
first GLP. um, I always ask my people that are following me when I'm doing a live, do you know where the GLP-1s came from? Like Ozempic, Wegovy, Byetta, Trulicity, Victoza, Saxenda. Do you know the origin of these? It's a very naturally occurring substance.
Yeah, it's the venom of like a lizard, right? Like
A
a
lizard.
Bouvier.
Yeah, it's the venom. It's a venom of the Gila monster. It's a lizard in Arizona. The guy was trying to patent or sell the drug for a very long time, like since like the 90s, and no one was buying it. And then it was called exenatide. I think his last name was Eni, Dr. Eni or something like that, or he's a scientist. No one was buying it. So then finally a company did, and they made Byetta, and it did really well. The original concerns were that it's the only reason it's causing weight loss is people were so nauseated and like they couldn't eat. But then they, like did a long, research study and found out that that's not the case. More people were losing weight than the amount of people that were actually getting nausea. So the people that dropped out of the study, I think it was like 14% of people dropped out, but the amount of people that were losing weight was like 30 to 40% of people. So like, that doesn't correlate. It's not that. It's not that they're so nauseated and so full. There's got to be more to it.
Yeah.
So you go on.
Oh yeah, yeah. We definitely there's like a lot of mice studies too where they actually just inject the drug directly into the brain as opposed to letting it go on the periphery, and they lose the same amount of weight. So it's definitely working like, centrally as opposed to just being like slowing down the gut, and making them nauseous. It looks like the nausea is also central as well because when you inject the mice in the head directly into the brain, so the drug doesn't really go in the periphery, they still get nauseated. So the nausea also seems like it's pretty central as well. That's why it gets better with time.
Yeah, it seems like there's something magical about these drugs, and I don't know about you, but I have seen, and maybe we'll get into this. I posted a recent podcast about it. But people are having like massive amounts of weight loss with certain combinations of these drugs, and maybe we'll get into. I had a guy lose like 130 pounds almost in like since April. Like literally, I saw him a few weeks ago. 130 pounds gone since April. Now, obviously, he's starting at a much higher weight. He was like 470 ish, and now
Oh
he's
yeah.
like 320, 326. So, obviously not everyone's going to lose 100 pounds if you don't have 100 pounds to lose, but we'll get into that. So you're obesity medicine certified. Tell me what that is and what that means.
Yeah, so essentially when you finish medical school, you're going to end up having to do a primary specialty. So that means either general surgery, internal medicine, pediatrics, whatever that is. After you do any general specialty, you're eligible to take continuing medical educations. Um, I forgot how many credits you have to take. I think maybe 60 to 100 hours, something like that. And then you can qualify for taking the exam. And then the exam is just like a typical board exam. You go into a prometric and you take the exam. And essentially, if you pass the exam, you become obesity certified. Then you have to keep up with a certain number of CMEs to remain with the certification. So because it doesn't have to do a lot more training in inpatient, For right now, it might develop as a fellowship later on now that there's more and more drugs. So, when it becomes, I mean, there's a lot more coming down the pipeline, so it might require fellowship in the future.
So talk to me about weight loss. Let's like back up a little bit. Why do people gain weight? Like I know we have this huge obesity epidemic. If you look at the statistics, 70 to maybe up to 80% of people are overweight, about 40% are obese. Um, Children age 5 to 19 are also like almost 20% overweight. Talk to me about that. Why do humans gain weight? Maybe the science behind it, the hormones, everything. Just give us a background information. Why do people gain weight?
Sure, yeah. That's actually a much more complicated question because of there's so many different mechanisms after you've consumed food and what the body does in order to channel that food into different areas of the body or what it's going to do with that food, in terms of making a person gain weight. It really does kind of come down to calories. Eventually, a person will have to consume more energy than they are burning off, and that energy will then be stored as excess fat in order for the body to have that energy whenever there's a famine in the future, in a sense. But the issue is that why are people suddenly in the last 30, 40 years starting to gain significantly more weight than they used to in the past? And it seems to be that we have access to a lot more food than we used to have. The food tastes a lot different, a lot better. I guess you could make the argument it tastes better, but it is hyper palatable. It can cover its lack of nutrition, so it's much more processed than it used to be in the past. It's extremely convenient. It's extremely ubiquitous. So starting to cut it out of our diet is difficult. We have new cultural round food because of its ubiquitous nature, and then you compile that with the idea that we also are the foods itself are starting to act like almost like a drug to us. So they have almost like addictive like properties, and so we're essentially, because of all that combined, we're essentially starting to consume more than we used to consume, more than we need, and it's essentially elevating our fat set point and making us gain weight over time. And that elevation has to do with the food itself and the other factors that might be affecting our lifestyle, such as lack of exercise or different sleeping habits, and sometimes medical conditions or medications that we might be inducing weight gain with accidentally over time.
So talk about this obesity set point or the weight set point. Tell us more about that? Because I know there was a book written by Dr. George Blackburn out of Harvard called How to Break Through Your Set Point, or breaking through your set point. Talk about that. What is that and what does it mean?
Yeah, so essentially, the body adapts its metabolism and adapts to you trying to cut your calories for too long or increase your calories. So your body kind of settles at this range, kind of like an equilibrium, where that's the weight that your body's kind of comfortable with the multiple variables that are coming in. So let's say, for example, you start walking half an hour a day. You're going to lose a little bit of weight. Possibly you're burning a little bit more calories, but essentially you're going to reach a new equilibrium, and you're not going to lose weight no matter what intervention you do. You're never going to gain weight indefinitely nor lose weight indefinitely. You're just going to reset that range that you're going to kind of go into. Um, and that range can vary for individuals, and that's what we call kind of the body set point. If you try to break through it, let's say you try to lose weight, then you'll start feeling a pressure to try to regain that weight back. That pressure can be with increased hunger, increased palatability of food starts to taste better, or metabolic adaptations where your basal metabolic rate starts to actually decrease, so that you are essentially burning less calories per day out of your control, and then making it more and more difficult not to start to regain the weight. So we have studies kind of out of Kevin Hall's group with like The Biggest Loser showing metabolic adaptation. The Biggest Loser was like a TV show where they were like really strict on getting to go into extreme calorie deficits, and essentially they start to gain the weight back, and they can see that their weight gain back was partly caused by this metabolic adaptation, despite the fact they were putting in a lot of effort. And then we also know that like the hunger and the kind of the food noise starts becoming really loud in someone's head, and making it very difficult to maintain a diet for a very long period of time if they kind of get through that set point. And it has to do with multiple variables. Like if a person's lack of sleep, they might start to go up. Yeah, essentially the medications are working in a sense to lower that fat set point, making it easier to lose weight. But even with the medications, you won't lose the weight indefinitely. You're still going to hit like a new set point in a sense.
Yeah, and I think the first time I read about the set point was when I was reading about the Vermont prison experiment.
Oh, well,
And
yeah.
you're not allowed to do experiments on prisoners anymore. But essentially, for those who don't know, they took half the inmates and they overfed them, and half the inmates and they underfed them. Super controlled environment. You can't leave prison, right? It's almost like a metabolic ward study, but with non-paid volunteers. I don't even know if they're volunteering. It's coercion maybe at that point. But they found that, the group that ate less lost weight, the group that ate more gained weight, and then they left them alone. And then they all got back to their starting weight when you just kind of left them alone, their body just readapted, told them, send hunger signals to one, satiety signals to the other, and they all regained their weight back. So then how does somebody break through their set point? Like, let's say you've always been 220 pounds and you don't want to be 220 pounds. How do you break through that and not have your body defend that higher weight?
Yeah, I think that's difficult. I mean, as you're what do you normally do as a personal trainer, I guess, when you're dealing with your patients?
So normally, from George Blackburn's book and studies, he found that if you can get the person to a lower weight, however you do that, you can have them try to exercise it off, eat less, whatever. It's a calorie deficit mainly. But if
Mhm.
you can get people down to 180 and keep them there for at least 6 months, then that'll be like the new defended body weight or the new set point. Their body will try to stay around 180. They were 220, they got to 180, they stayed there for at least 6 months minimum. He says even 9 months sometimes. But if you can get to like a new body weight and stay there for a long time, then you're less likely to have your, you know, defensive mechanisms on your body try to fight you back up to back to the higher weight. So, and the
Right.
same thing in reverse. If you went down to 160 or you went up to like 260 and you left them alone for 6 months at the new 260, your body would now defend the 260 instead of back to 220.
Gotcha.
So,
Um, so we typically the way we typically approach it is and I what we're doing is we're kind of compiling different studies because we know, for example, studies on improved sleep help with weight loss. People with exercise, exercise in itself doesn't burn that many calories. However, people who do exercise are more successful at weight loss and maintaining that weight. Things like studies with the microbiome, seeing that diets that have foods that are better for the microbiome do cause more of a calorie deficit that is able to be maintained with satiety signals still being elevated, despite the fact that they're more in a calorie deficit. So we try to combine all of that as different variables, and we look at the fat set point as that your brain is kind of looking at all the variables in the environment. And if you try to kind of perfect each one of these variables, it might help you break through a plateau until you get to a reasonable weight. So part of it for us is kind of defining what is a reasonable weight. So if I'm talking to like a bodybuilder who's trying to get like to 5% body fat, this competitive weight is not something that I'm specialized in there, and this is not something that a normal person can sustain for a long period of time because they've gone too far away from that set point. But also, if somebody's morbidly obese, their body doesn't typically want to be morbidly obese. So getting them down, it's easier to maintain them. So like you had mentioned, like your client who had lost like 100 pounds, and they were about 400 pounds. So they might find it easier to maintain at 300 pounds, despite their health might be significantly improved than somebody maintaining at a 4%. So we kind of try to fix these variables all at one by one while inducing a calorie deficit that's reasonable for them to maintain. Once the calorie deficit is kind of resumed, we want those variables to stay in place, like the improved sleep, the eating, choosing whole food options, things like that. So they remain sensitive to the satiety signals. And then we and then we use medications if we need to. And then we do try to sustain it for a period of time. For us, we find that 4 months is kind of the golden period. Not 4 months meaning that their fat set point has reset technically, and they can go back to bad eating habits again in 4 months, but more that 4 months is about enough time for us to find that people have adjusted their palate, what they find tasty. I mean, if I cut out, for example, a Pepsi for 4 months, if I go back and drink it again, it's going to taste like battery acid. And then it's going to take some time for me to get used to it again. And then suddenly it's going to start tasting sweeter. And then all of a sudden the carrots and the fruits are going to taste less sweet. So it takes for us about 4 months for them to adjust their eating habits and then get used to the new way to eat. Like, okay, this is what's most convenient. This is the food I do like that's healthy. This is the food I don't like that's healthy, and kind of allowing a person to experiment while they're under supervision. And then once we stop, then usually as long as they can maintain those new habits and they don't go back to how they were before, hopefully they usually maintain the weight for the most part. They go within their range. Like they might lose or gain about 5 pounds, but usually at that point they're able to maintain. If that makes sense.
so you talked about calorie deficit. At what kind of a calorie deficit do you shoot for? Does it depend on the patient's starting weight, or do you have a formula you use? Like like somebody comes to you and they're 285 pounds and they're like, I want to lose weight, doc. What is your approach? How do you approach the patient? Assuming they got sent to you because they kind of tried most other things. So they,
Sure.
they come to you and like, how do you decide the calorie deficit? And then at what point do you decide to add on or not add on medications? Like, what is your approach? Pretend I'm a brand new patient. I'm 280 pounds and I want to lose some weight.
Sure. So we generally develop certain rules that we have, that those rules are foods that we do like them to cut out completely because it makes it very difficult for them to count their calories. So example, if you take a food and you have it deep fried, your calorie counts on those foods are going to be very difficult to actually have because you don't really know how much oil was absorbed, how much water was displaced of the food. So if you were saying like I'm going to have, I don't know, a donut, for example, like that's the size of the donut, even if it's one donut is like 10 grams heavier than the other, that might be a substantial difference in the calories because you dehydrated the donut and added a lot. We usually ask them, there's certain foods that we want kind of, I don't like to say an absolute no-no, but like there's certain foods that we really would like to remove as much as we can. And those are usually liquid calories, such as soft drinks that aren't diet, for example, and foods that are deep fried. Uh, and uh, and and then we want to kind of watch the salad dressings, the oils and dressings that can be added to things, because those can you could if you make a mistake and you add an extra tablespoon of olive oil, you're gonna wildly throw off your calories. But if you add in like an extra 4 ounces of strawberries, you're probably not going to wildly throw off your calories at that point.
So
So
how do you give them a number? Do you say this is what we're shooting for in terms of calories or not really?
we find that that's not helpful because usually by the time someone has chosen to come to us, we're going to be more expensive than what they probably attempted. They probably already attempted counting calories, and normally they attempt using MyFitnessPal. They put in like a calorie deficit in MyFitnessPal, and they start scanning everything. We do have them send us pictures of their meals, and we find that they wildly misestimate their calories, wildly, like they're way off. So we don't find it to be that beneficial. We find it's more beneficial that if we can remove certain foods and then give them meals that they like, and they just keep eating these consistent meals. And if they're not losing weight, we just chip away at that meal that they already like. So if you like
So
tacos, for
give me an example of what that looks like.
so let's
So,
say
because I usually have, because the reason is because I usually have my patients do my fitness pal or some kind of tracking. Like,
right,
listen, either take pictures of your food, use like one of those picture apps, or track in my fitness pal or something. You just need to get an idea of how much you're actually eating. And my philosophy is even if they're tracking wrong, they're at
yeah,
least tracking and we can adjust it. Let's say they tracked that they ate 5,000 calories, but really it was only 4,000. When we
right.
tell them cut it to 4,000, they're really tracking and eating maybe 3,500. But for them, in the way that they're tracking, as long as they do it consistently, even if it's off by 20%, 30%, at least we know we did cut it. Or if they're starting to gain weight, same thing in the opposite direction. So
Right.
how do you, I guess, approach that?
So after we've already removed deep fried foods and liquid calories, and then we kind of teach them how to watch out for the oils in dressings and things like that. And sometimes we give them a shopping list of where to replace things. We find that they already start kind of losing weight at that point in time. But let's say, for example, we're looking at their meals, and for in the morning they're having like I don't know eggs and bacon, having like 3 eggs and 2 pieces of bacon, and then for lunch they're having like a sandwich. And then at dinner, they're having some type of, usually some kind of carb, some kind of vegetable, some kind of protein, for example, and we find that they're not really losing weight. Then we look at the meal, we just say, all right, so let's try to get 20% of these calories out. So we'll say, hey, for that sandwich, let's watch the dressing. Let's switch off the mayo for mustard, for example. That morning, those 2 eggs and that 2 pieces of bacon, we get it down to 2 eggs and 3 pieces of bacon, or let's add an additional egg and take out one of the pieces of bacon because of the fat content of the bacon. And then for dinner, let's increase the protein content and decrease maybe a little bit of the carb content, increase the vegetable content. Just doing something like that, like rearranging the food very slightly makes it feel like it's not that limiting, but then at the same time we have decreased the caloric content about 20%. We might incorporate intermittent fasting depending on their lifestyle. So sometimes they'll be like, listen, honestly, I don't really like breakfast that much. I don't have time. I'd rather have a cup of coffee and be out the door. I feel like breakfast is the most important meal of the day. And we're like, well, you know what? Let's just cut out breakfast then because it might be more convenient for you. I'm like that. I would rather just skip breakfast altogether, and that will put me in a calorie deficit because I'm usually out the door by 6 a.m. Seeing patients, pretty busy, and then by lunchtime, I'm okay having a meal then. So we might
So
rearrange the meal that time that way.
So you don't actually so no calorie counts. You just tell them cut this, cut that, cut this, cut that. But the problem is, I think, at least from what I've seen, and I don't know how successful it is. Maybe it works in the way that you present it, but your body obviously has like these defensive mechanisms. They
Mhm,
start. You tell somebody cut this out, cut that out, cut that out. Now they've created a calorie deficit of 1,000 calories, let's say, or whatever it might be,
mhm.
and you are they're losing weight, they're losing weight. I find that usually after about a month or so, their body's like, we've lost like 20 pounds or 15, whatever it is. We got it. We don't want to do this. We got to gain our weight back. And it starts sending the hunger signals again. And they maybe are not as strict with what they're doing. They feel like they're on cruise control and they slowly gain the weight back. We see that a lot. So how do you mitigate that?
So that is I think a problem across the board. I think nobody can really get around that problem. One of the ways that we try to mitigate it is that we just try to increase the exertion along the way. So we know that they're going to rebound the moment they stop the diet. So that's what part of the reason why we haven't been a huge fan of calorie counting. I'm not trying to say it doesn't work. It does work to do. It's just the issue is
Sure.
that as a person, I used to calorie count myself. Usually about 3 months in, you really start to burn out from doing it. And sometimes even when you're calorie counting, you start creating a list of foods you don't want to have anyway. So you kind of realize that you're like, dang, cucumbers are really low in calories, but like if
Yeah,
I
I
have
agree.
olive oil, so you just start like putting out that food altogether. So just easier. Someone just tells you, like let's just skip the 3 months of you experimenting. Let me tell you that like, hey, that salad dressing that's going to add in calories really quickly without making you sit, full. But those eggs or chicken breast is going to be really filling. So just kind of like we're going to kind of get to the same conclusion anyway. So we just try to give them kind of a heads up on that conclusion. But the rebound effect
So,
for
but it sounds like yeah. So they're doing it. They're doing what you say. They lose the first 15, 20 pounds, and as time goes on, that weight starts to creep back up again. What do you do then?
so
Before medication. So, assuming right now no medications, nothing.
yeah. So typically we if as long as you're doing the kind of the triangle is kind of sleep, diet, and exercise. So if you're doing all three of them together, typically the body recomp helps with the motivation of it, and we do have a pretty good weight loss. Now, usually if they skip one of the three, if the sleep goes poorly, if the exercise goes poorly, the diet usually kind of falls apart as well. So we feel like we do all three together and we can keep those consistently going, then they all kind of feed each other as they're starting to lose the weight. If they start creeping up, we typically don't see the creep up happening if a person is sleeping well and hitting the exercise well, and they're still pretty cognizant of their calories. They really have to give out all at once to kind of have that weight kind of creep up for us more substantially. But typically, we find them when they get to an equilibrium, if they're still not losing or they're getting to a plateau, we sometimes try to find a place to break that plateau. We might increase the calories slightly, maintain them there for a period of time, just so they have that relief, and then go back into a deficit again. So that's one possibility that we might do. The others we might change their
That's usually called a reverse diet.
right,
Like a reverse diet will go back into a maintenance phase. A diet break. Take a break from your diet because it's mentally tough, it's physically tough, it's exhausting.
right,
Just take a break, increase your calories, and have a little more fun and move on for a few
exactly,
months.
right,
Yeah,
exactly.
we do that. I've done that with a lot of people, and it really works. It kind of like resets them mentally because it's hard to like stick to a restriction, obviously.
Yeah, it is exhausting. So that's
But to tell me about the sleep thing, what's with the sleep thing? What do you tell them?
so we want them to sleep at least 7 to 8 hours a night. So we really emphasize the 7 hours or more a night. I mean, we've had people,
And how does that? What's the mechanism of that? How does that kick in? Obviously, I'm all about science, so
yeah,
I know there's a lot of people out there that are like, "Well, you just need to sleep and you'll lose weight." Like, no,
yeah,
like that's just nonsense. You also have to restrict calories. You have to do a lot of what you're saying too.
right.
But like, what is that? How does that work?
Well, if you look at the studies, when you look at like the semaglutide studies, when they try to put them in a moderate deficit, so they put the placebo group and the group into a deficit. The placebo group was doing 500 calorie deficit per day, and the control and the medication group was doing 500 calorie deficit per day. But they lost the weight; they lost 15%, and then the other group didn't lose as much as them. When they did it more restrictive, they did the study again more restrictively. One of them was doing 1,200 calories per day. The semaglutide group still beat them. They still were able to eat 15% less. So the question is that so does that mean that counting calories and cutting calories doesn't cause weight loss? No, it just means that they weren't compliant. The 1,200 calories, they were unlikely eating 1,200 calories consistently. They probably were starting to cheat. They probably don't feel it. They were putting in the effort, but they were unlikely able to maintain that deficit. So those mechanisms that we talk about in order for our body to regain the weight, the minority of those are actually metabolic adaptations. The majority of them is just your willpower giving out, starting to cheat here and there. That's really the majority of them of how the weight's being regained. So it is true. I mean, if you're 200 pounds and you drop to 150, you're carrying around 50 less pounds. You are and that tissue you lost was metabolically active. You are burning less calories per day now. But the
And
regaining
you need less calories usually.
and you
Like
need
a
less.
lot of my patients will be like, I was eating 1,800 calories, doc, and I got down to 170 pounds, and now I'm not losing weight anymore. Well, because that 1,800 now is your new maintenance at 170 or whatever the weight is. I'm just using an example. You
Right.
might have to cut it a little if you want to go down, or take a diet break, increase it back up to maybe 2,100, and then later on go back after it. Let your body adapt to a higher level, higher metabolism, and then go back down.
Right, exactly. So from our perspective, when they use the semaglutide, what it's actually doing is it's allowing them to sustain the caloric deficit for a longer period of time, so they are able to be more compliant on their diet and sustain the results. No trial was done on Ozempic or Wegovy, and they weren't inducing a calorie deficit. They always had a dietitian. They always had a workout program. when they were doing the studies. They weren't just taking the drug and losing weight. And if someone is taking the drug and not trying losing weight, they're still in a caloric deficit. They're eating less than they are.
Oh, they're absolutely losing weight. Like I did a podcast the other day. We can force you to massively lose weight now, and we'll get into the medications
Yeah.
later on. But
Um,
like, if you send me a patient that's 300 pounds, I can get them down into 100s so easily now. Like in the past, it used to be, come on, start taking this, do that, try this medicine, add on this, and like we had to add on metformin and Topamax and Belviq for a while before it disappeared, and like all these other things, and phentermine, diethylpropion, whatever. You had to keep stacking things on. It's like, oh, and they're barely losing any weight.
right.
Now it's like they don't even have to try, and that's the thing. Like a lot of people are like, this is like phentermine, for example. Is like, oh my god, this is like willpower in a bottle, doc. What is this
Yeah.
stuff? And
Right.
it's like they're like, oh my god, I don't even have to try to even lose weight. I have like willpower. Like one of my patients recently told me she would be at night. It's time for supper. Before she'd be like, oh, it's time to eat. I'm bored. Everybody's eating,
Mhm.
time to eat, even though she's not even hungry. Now
Right.
it's like, I'm not hungry at all. I'm disgusted by eating. I'm not going to eat, but I'll sit down with you guys and enjoy watching you guys eat or pig out or whatever the word was she used.
Right.
But like it gives them this immense amount of self-control and willpower. Like you said, probably the medications are giving you a calorie deficit, making you maintain a calorie deficit more easily
Right.
for a longer period of time without you trying to like will it. Like people are like, I'm just gonna power through and only eat 1,400 calories a day, and I'm gonna be like super strict, and then like they fall off the wagon or something happens. There's a wedding, who
Right.
knows? It's whatever it is. But
Exactly.
this gives them like immense control, willpower, whatever you want to call it. We'll get into the medications, I think, maybe a little bit later, but I'm sure you've noticed that too, that they just like all of a sudden the weight just starts coming off and they're like, oh my God, I can't believe how much I used to eat, or now I don't eat anymore. So I think that part of the medications makes a huge, huge difference.
Definitely, yeah. So when we look at sleep, kind of going back to sleep, the what we're looking at is that we want to make sure that the rebound is going to mostly occur because there's increased hunger, there's increased appetite, and there's decreased willpower. So we're trying to enhance those as we're keeping the caloric deficit going. And the sleep is essentially doing that because we know from decreased sleep there is more caloric intake, there is an element of decreased burn, there is increased ghrelin levels, so it changes how the satiety signals. And kind of the way we approach weight loss is essentially it's not a problem of overeating, but it's a problem of not feeling full after the meal. So you look at the skinny guy that's never been overweight and you're like, he eats horribly, but the reality is he probably feels full faster and he is going to carry over that horrible meal, and it's gonna be longer before he gets hungry again, or she gets.
That is absolutely true. The one strategy I used to tell my patients is like, listen, here's what you got to do. Eat half of what you would normally eat, but wait 20 minutes because there's a really long delay between your stomach feeling and knowing that it's full, because there's vagal nerve is down there and there's these stretch fibers in addition to the hormones and all that stuff. But
Exactly.
these stretch hormones and the stretch fibers, that's why like drink 2 tall glasses of water before you eat also works, because you start that stretching sooner.
Mhm.
But wait 20 minutes. If you are still hungry, like literally time it. I tell them, get a stopwatch, watch it on your clock, set a timer, eat, then eat half your food, wait 20 minutes. If you're still actually hungry, then go back and eat a little bit more. Don't go eat the whole thing, the whole other half. But you'll notice that a lot of people are like, you know what, doc, I did what you said and I lost 70 pounds because the signaling, the satiety signaling is delayed in
Yeah,
the in normal humans. And maybe, with people with obesity also have a lot of like dysfunctional appetite. I mean, the studies have shown that too, that
definitely. Yeah,
if you are obese and not active, you have a dysregulated appetite. You don't know really when you're full, or it takes a really long time before you're actually full, and you're not really sure when you're hungry. So a dysregulated appetite, we have found, like you said, that if you were to exercise, even if it's just walking,
yeah,
walk a little bit after a meal or just somewhere throughout the day, walk a little bit, your appetite dysregulation will slowly improve. Same thing with this kind of strategy of like waiting 20 minutes. Let your stomach realize that it's actually full to turn off that, brain hunger, so that you don't have to eat the other half of the rest of your calories. So I think even before medications, we've had strategies like that, and it definitely seems to have helped. There was a study, and I have it in my really long YouTube lecture. Maybe I'll link it below. But there was a lot of studies on that dysregulated appetite and just a little bit of activity. And it also had to do with like how obese you were. The
mhm,
more obese you were and the less active you were, the more dysregulated your appetite is. So a lot of what you're talking about probably helps reset that.
yep,
And I know like with some of the medications, they just jack up your metabolism too. But I think we'll get into that stuff later. But in terms of exercise, what do you tell? I have a lot of patients, and I'm sure you do too. You got a 370, 420-pound patient, and they're like, Doc, I can't exercise. Look at me. I can barely get up to use the bathroom. What do you tell that kind of a patient?
Yeah, so it does definitely depend. If a person has BMIs that are significantly elevated, like we're talking about BMIs of 35 to 40, we at this point we're going to start leaning towards medication a little bit earlier so that we can kind of free them up and not hurt their joints. So get them out there, get them walking again. So if I get somebody who's 400 pounds, I start on medication, I get 50 pounds off. All of a sudden, I'm going to save his joints, and now he can start doing the walking. Suddenly, the weight's really coming off because we kind of opened up that door for him, and then we're more able to wean off the medications afterwards. So it really depends on where the person is. Sometimes I like to remind people that I'm an obesity doctor, so the patients I'm dealing with have obesity, and obesity is leading to other medical problems, as opposed to just like you have a BMI of 27 and you're trying to look, get the 6-pack abs. I might not be the best person to talk to about that. There's a lot of bodybuilders, a lot of people on TikTok and stuff like that know that stuff better than I do. But typically we like to start. We separate exercise into 4 categories. Essentially, we have aerobic, like low level aerobic, like walking, light level stuff where you can still have a conversation, resistance training, mobility, stability. So like stretching, yoga,
Flexibility.
yeah, flexibility. And then the third is like high intensity interval training. So because we're not really training athletes, we're training more for health. We like to start off with low level aerobic training. So make sure they're getting their steps in. Some of our patients will start off with like less than 1,000, 2,000 steps per day. So we need to get that like above 7,000 steps per day. And usually a half an hour walk can get you there. And then we like to do resistance training because a lot of them have never done resistance training before. And that's where you really see the best transformation, the best bang for your buck. If you do a lot of HIIT, you do a lot of cardio, it's great for you. It's just that you don't see that much feedback, especially if you're a novice, compared to resistance training for 6 weeks, and all of a sudden you have biceps you can flex. You're like very motivated, and that's really part of what we need to do. Yeah, that's what we're talking about. So as long as we can, so we tend to emphasize low level aerobic activity to kind of get those joints moving again, and then we'll emphasize resistance first. Once they've been doing resistance for a while, we'll start adding in mobility, stability, but we typically combine the two. So we'll try to get them to do full range of motion during the exercise. And usually if you're doing full range of motion on weightlifting exercises, you are probably getting a lot more mobility than you would have had prior to not doing any resistance training. So that's usually sufficient. The high intensity interval training depends. I mean, if I have a 75, 65-year-old female who's coming in for weight loss, I might not emphasize any high intensity interval training for them. It might be sufficient to do resistance and just aerobic training for them. We find it's it's effective on multiple fronts. It helps the body recomp, because a lot of times people with weight loss, it's really body recomp that they want. They want to look better overall, and that's going to be a big component of that. It's going to help with the weight maintenance. It's going to develop a new culture and keep them motivated. So this new identity around fitness and weight loss occurring. And then definitely it does improve their satiety signals. And we know that in mice pretty clearly, like with lac feed, that there's a metabolite that's produced with intensive exercise that improves a person's satiety signals. So while the calories are not really burnt that much, you really can't compensate the calories you did with the exercise. You probably are going to have better satiety signals. I know that, for me, example, if I go for a half an hour walk or I work out that morning, I can deal with my cravings much better throughout the day than if I just kind of been laying around all day.
So my philosophy is similar. If somebody is that overweight, like they're 200 pounds overweight or more, I don't even talk to them about exercise. Because like I said, they're going to be like, Doc, I can't even get up to use the bathroom. You want me to get up and walk? Like, how do I even do that? So for them, like you said, focus mainly on weight loss first. Drop that first 20, 30, 40, 50 pounds. Then they're like, Doc, you know what? I can go up. I can get up. I can walk around. I feel good. I'm doing this. Then slowly work in the rest of the modalities and get more and more intense. And I obviously always emphasize, just like you said, not just cardio. A lot of people just tell their patients, oh, just go for a walk. No, but you have to do resistance training, because sarcopenia is real. And for those of you who don't know, sarcopenia is like losing muscle. As we get older, you lose more muscle. A huge cause of debility in the elderly is muscle loss.
Yep.
And you can't walk, you need a walker, you need help getting out of a chair, like, all that stuff. But the more exercise, the more muscle you gain now when you can, especially for young people, if you're in your up to 50, maybe 60 years old, and you're still quite fit, the more muscle you put on from now, the more functional you'll be when you're 80, 90, 100, who knows. So definitely I agree completely with that. And definitely a lot of the super overweight, and there is actually a medical term called super obese, so we're not making fun of them. This is actually a medical term.
Mhm.
But for the super obese, definitely start with the medications almost immediately, get weight off so that they can actually do things. Absolutely
Yeah.
with that. So let's talk medications because I think probably a lot of people are like, you guys are just telling us what we know.
Mhm.
Right? I mean,
Yeah.
move more, eat less, which I get that, but there's a lot of, like we said, like you heard, hormonal stuff, social determinants of health and food environment, ultra processed everything.
Right.
All of that makes it harder and harder to eat more, eat less, and move more.
Right.
And not all of it is your fault, obviously. Some of it you can't control. So now let's hit medications. What is your approach to patient comes in, has tried most things, you got them on your program with the cut out the fried stuff and all that. And now you want to start with the medications. Where do you start? What do you do?
So we like to do an all-encompassing approach at one go when we start the medications because our goal is to stop the medications. I'm a little bit in disagreement. The
Say
majority.
that. Say that again. I think I missed the first part. You said
So
what?
we start the program from the very beginning, kind of adjusting for ourselves that there'll be a rebound when they stop the medication, but we do plan on
Okay.
stopping it. Yeah. So it seems like the kind of the culture around the obesity societies and the medical societies is that obesity is a chronic medical illness and therefore it needs chronic medical therapy. Therefore, you have to start these medications for life if you get on them. And the ones that they're going to be emphasizing is the GLP-1s because those seem to be the safest to be on for a long period of time, as opposed to the other medications like phentermine or Contrave, which is not that effective. The goal is that you start on these and you remain on them because when you stop them, you're going to rebound in the weight. And it's true that studies do show that patients who got off the medication started to regain the weight back. They don't go 100% back to where they were, but they do slowly regain the weight. But we find that it's impractical to assess somebody on these medications forever because you have younger people on them that might become pregnant in the future, and they're not studied in pregnancy, so you're going to have to stop it anyway, and then you're going to have to resume it. Because insurance coverage and price of the medications and shortages, most people are off of them within a year, whether you like it or not, because it's hard to find. People don't want to change jobs because they might change insurances in that regard. They have a hard time with PAs, and the coverages are getting worse, not better with time. They might get better in the future once we have like pill versions of these medications, which are probably going to be around the corner. So we kind of start with that kind of mentality in a sense. So when we start, we start them usually on a GLP-1 if they qualify. The GLP-1s just have the best track record of safety. They have the least amount of side effects that we have to worry about, and they don't really interact with other medications that well. And they're getting other comorbid conditions, so I don't have to worry about if somebody has a history of AFib or CAD. There's a little bit of
So let me tell you, just a brief interruption, and I don't mean to like cut you off, but almost all of my patients have hypertension, AFib, everything you can imagine that is worsened by stimulants. And if we have their hypertension under control and their AFib is under control, and their tachycardia, SVT, whatever's under control, we still will use phentermine, diethylpropion, all that other stuff. But go on, sorry.
Yeah, so we
But a
still
lot of times that's why they send them to me. They're like, you go deal with it. They have millions
yeah.
of heart problems. You're the heart guy. You take care of their weight loss
Well,
too.
if you induce AFib, you're going to be confident treating it as well.
I'll fix it, right?
Yeah. So typically we'll start off the approach by doing a GLP-1. We do monitor for other medical illnesses and try to get things under control because unfortunately, uncontrolled sleep apnea might hinder the weight loss. If they have hypothyroidism, it might hinder the weight loss. Cushing's might hinder it. Uncontrolled asthma.
Testosterone, even.
Yeah, testosterone might do it. We have a lot of because I'm an allergist as well. We might have uncontrolled asthma, so they're getting steroids like every 2 months for the uncontrolled asthma. So we have to get that under control. They can't go for walks outside because they start sneezing all the time. We might have to get that under control. And then medications, we might ask the PCPs to change some medications around. If they're like on atenolol, which is not a great blood pressure medication, we might ask them, hey, like, can you do a calcium channel blocker instead and try to wean off the beta
Or
blocker?
lisinopril. And lisinopril actually has a side effect that is weight loss. Yeah,
Mhm.
metoprolol and atenolol, those two specifically, is zero blood pressure. Like they
Mhm.
literally just slow your heart down.
Yeah.
The other ones do have some blood pressure control, but lisinopril, ACE inhibitor, viper venom, is where it comes from.
Yeah.
That actually does have as a side effect actual weight loss. So,
Yeah. You see any weight loss with hydrochlorothiazide? The diuretic
just a
does not
little
wear
bit of
off.
water weight. It's a diuretic for like 2 or 3 days, and then after that, it's not. It's a more of a arterial dilator. So all of those are like minimal, even amiodarone, like all this. The one drug that primaries and psychiatrists use a lot that causes massive weight gain compared to the other SSRIs is paroxetine.
Mhm.
So if anybody's on paroxetine, and I don't know the brand name of it, but paroxetine, like we'd rather have them switched to like even just Wellbutrin, because Wellbutrin actually is anxiety depression medicine that was also used for weight loss.
Yeah.
It gets rid of like that food noise, the cravings. It's used for smoking cessation. I've put a lot of people on it to help them quit smoking, help people quit eating, I guess, if you want to call it that. Wellbutrin would be the best option of those. Paroxetine is the worst option of those. That's, if you had to pick one.
Right. We do
So
use Wellbutrin as well, and that's been pretty helpful for us as well. So yeah, so
so
we
you start straight up with GLPs.
yeah, GLP-1s, and often we'll use phentermine. So we'll use a lower dose of phentermine. Maybe we'll have to compound a 7.5 or use Qsema, something like that. We usually do both
The
of them.
problem is getting Kissimmee paid for. It's
Well,
just it's not,
GLP-1s
it's
too.
branded.
Yep, but we can use straight phentermine.
Yeah,
Uh,
that's what I do. So my approach is the exact opposite.
yeah, we go
I
with
usually put them on the highest dose of phentermine, 37 and a half. And I'll say, you know what? You've not been on anything. Let's just try this. Because, man, some people, it just works. And why put them on expensive injections, once a week injections? And we didn't have the once a week stuff till just recently. We were doing every day, Saxenda and whatever,
right,
Victoza once or twice a day. Why put them on something that's an injection if a pill would work, right? And we've had these pills around forever. They're generally safe. I'm a cardiologist. Obviously, I can deal with the side effects, and if they have them, but for the most part, they're pretty safe. So I usually start with that. I'll start them on the phentermine, see how much weight they lose. Now, if they come back in a month and they're like, "Doc, I lost 0.2 pounds," I'm like, no, you didn't lose anything.
yeah,
That was you, like, cutting a little bit of hair off the side of your head.
right,
So that then I'll be like, all right, this is not really working. So usually what I'll do first and foremost is I'll put them on phentermine and metformin together.
hmm
The metformin also causes some weight loss. Now it's not massive. It's 5 to 10 pounds, maybe 3 to 5% of your total body weight, but it helps later if they need to be on Ozempic or Wegovy or any of the, Manjaro that are only approved for diabetes, or like it's much easier to get it covered for diabetes than actual weight loss. Plus, all my patients are usually already insulin resistant, have high triglycerides, cholesterol. So metformin does help lower your triglycerides. So you put them on for hypertriglyceridemia, insulin resistance, A1C it's elevated, impaired fasting glucose, and it's not hard to prove these things. Like with a few little lab tests, a A1C, a fasting glucose, a fasting insulin, whatever, you can prove that somebody's insulin resistant, impaired fasting glucose, whatever, super easy. You can put them on those two. That's what I do, like phentermine plus metformin together, and a lot of people lose weight and just keep losing it, and I leave them on that. Eventually, when they're not losing weight anymore, that's when I'll say, okay, you know what, let's add on Ozempic. And because they've already been on metformin, usually it's a lot easier to get that approved, especially if they're diabetic, obviously. Makes that part a lot easier, and man, that's when you get like massive weight loss.
yeah,
And sometimes if somebody stops losing on phentermine, like let's say for like 6 months they're losing, it kind of slowed down, but they still got a ways to go. At that point, if you switch them to diethylpropion, almost they just start losing weight again because it's slightly different, doesn't have the anxiety, tachycardia, the mouth ulcers, the dry mouth. It doesn't have those kind of side effects, so they almost immediately start losing weight almost again. It's kind of like hitting the reset button. But that's kind of like how I do it. So after you do the GLPs, then what do? You add the low dose of phentermine. I keep them at 37.
yeah, because I'm anticipating they might be on it for a little bit longer. So I'll do the low dose of phentermine, and then I'll use metformin towards the end. And then usually when I wean off the GLP-1, they remain on the metformin for a period of time.
You'll
Uh,
put them on GLP plus metformin.
towards
Do you
the end,
take away the phentermine or you just lower it?
no, if I'm stopping one, the first one to go is a GLP-1 because that's the most expensive. That's where usually they lose
Oh,
coverage, and then
plus it's
GLP-1.
injection.
Exactly. So when we stop the GLP-1, we don't want them to rebound, so we'll keep them on phentermine and then metformin, and then we'll just kind of see how they're doing. If they're not regaining the weight, if everything's okay, the hunger noise is not that bad, we typically wean off the phentermine and just do metformin, and then they just kind of uh, stay on the metformin. And then if they're doing fine on the metformin, we'll wean it off if they want.
And then when you put them on phentermine to begin with, you start with the GLP, then you add phentermine. It's a low dose though. It's not the full. You're not doing the almost 40 milligrams or any of that because it does come in a 15 and it does come in a 20 some places, but those pills are usually more expensive. Some places they're capsules. So I
Yeah,
usually just stick with the 37 and a half. You can actually break them in half, the tablets, and
yeah,
it's about 20 milligrams, maybe just a hair under,
yeah.
because it's 37 and a half. It's basically almost 40. Cut it in half, it's a little bit less. That kind of works, and it's still cheap. It's still generic. It's not like the newer, lower, tiny doses that
It's
cost
just
a
it's
lot more.
small, so you can't break in a fourth. It's hard to break
Yeah,
it.
no, no, you can't break it in a fourth for sure, but
Yeah.
definitely could do about a half. Half, most of my patients are like they can, but almost none of them do. They just stick with it and it seems to work. So at the end of it, you take off the GLP, stick with low dose phentermine slash metformin, and then leave them on eventually just metformin.
Eventually, yep. And then we kind
When
of,
they hit close to their target weight or once they hit their weight or what have you.
yeah, exactly. So we'll just kind of, we anticipate, we usually aim for a target weight of 20% of total body weight. Once the 20% has been hit, we start, you tell them like, hey, if you get past 20%, if we tap the GLP-1, there's going to be a pretty good rebound, at least to back to that mark.
So
So
you shoot for 20% under what you want. Like
20%.
let's say they want to get to 150, you shoot for 130.
Oh, no, no. 20% of whatever
You
the starting weight is. So if they're starting at 200
Oh,
pounds,
I see. Okay.
we're talking about 40 pounds. We don't, if they say like, if they're 200 and they're like, I want to be 150 because I was 150 in high school, we just have a conversation on like, realistically, let's get to 20%. That would be magical if you can sustain 20%. We try to kind of, and most people are happy with that. Once they get to that, it's been a hard time to get there in the first place.
Yeah,
Uh,
definitely.
Yep, and then that's essentially it. And then the whole diet program, the whole program that we do is always coming from the mentality, not that it's calories in versus calories out. That is mathematically correct, but more of that. The reason why you're not able to sustain calories in versus calories out is because you have things working against you. Your satiety signals are off. So we need to correct those satiety signals, and we need to correct them through different mechanisms. And we do that through, like I mentioned, like sleep, exercise, certain dietary habits, getting rid of temptation in the house, for example, because even if you don't like Oreos, you want to have it sometimes, no problem. But after you've lost 20%, those Oreos are going to start really calling to you. So you really want to put in, you have to put in effort to get them in a sense. So I like ice cream, and I just had my birthday recently, so I'm about to try to lose about 15 pounds. And I really like ice cream. So if it's in the house, if you have like a bunch of Haagen-Dazs ice creams, I'm going to down them once I'm 10 pounds down. I'm going to regain rapidly. But if I have to go to the store and buy it and put in that effort, then it's fine. I can have it. It's just I won't be able to overdo it because I have to put in
You
that
put
effort.
more barriers.
Exactly.
Like you don't
Uh,
keep it in the house, you got to go to the gas station or whatever to buy it or whatever.
exactly. Exactly. So
So another thing I noticed, and I'm sure you have too, and this is scientific, like we know this. Oh, the adipose tissue, like fat tissue in your stomach, trunk, or area, legs, arms, whatever, it's metabolically active. So a
mhm,
lot of times, once people lose a lot of that weight, let's say they lose 20% of their body weight, 25%, what have you, um, that those hormones and that metabolically active fat tissue is a lot less. You notice that a lot of people no longer have as much food noise. Like, how we're talking about the dysregulated appetite. When you
right.
lose a lot of that weight, your appetite becomes a little more normal or more regulated so that you are feeling full when you're supposed to. You are feeling hungry when you're supposed to. The metabolically active part of the fat tissue that you have, now that a lot of it is gone, seems to settle in, and the food noise and the hunger cravings and all that stuff, your appetite is more regulated, or at least more back to a normal, closer to a normal baseline than what
Exactly.
it was before when you were way more overweight. I'm sure you've noticed that.
Yeah, right, definitely. And then typically, because to go into a sustainable calorie deficit without feeling hungry all the time, you typically have to eat whole food sources. And once you start doing that, your satiety signals start improving. So you had mentioned, for example, your delayed satiety signals. So the way we look at it is that there is a delay in satiety signals, but it's not actually a delay. It's reasonable for the food that your body's designed to eat. Now you're just consuming food that you're able to absorb too quickly, and now it seems delayed, but the reality is you're just eating too fast. So with Kevin Hall's experiment, they found that the calories per second was significantly increased with ultra processed foods, meaning for
The
they're eating,
calories per second.
yeah. So they're
Explain
essentially
that for our listeners.
so
Like,
essentially they're eating faster than whole food sources. So if you can imagine an apple, I have to bite it, chew it, and then swallow it, and every calorie with every bite is less than the calories I can do if I was eating a piece of pizza. So the
or drinking the apple juice.
or drinking the apple juice, exactly. So having that piece of pizza, every single bite might be, I don't know, I'm going to throw out a number like 30 calories per second. And then if I'm eating an apple, I might be having 10 calories per second. So that delay in satiety signals are designed for apples. They weren't designed for pizzas, right? So you can imagine if you were out in the wilderness, most of these foods, they require quite a bit of metabolic magic in order to get the nutrition out of when you're eating, for example, apples or celery or things like that. So we have to cook them. I mean, we digest our foods outside our bodies. We have to cook them. We have to manipulate the food in some way to get the nutrition out of the food. And now we just become so good at it that we can essentially just be drinking oil, and the calories per second start becoming significantly faster. So one way to slow yourself down is simply to eat whole food sources. They're just chewier, they take longer to eat, and they take time to prepare. The more
And
processed,
they take a lot longer time to digest.
yeah,
Because the sugar in the apple and the calories in the apple is surrounded by the peel, the fiber, all that fibrous material. To get at it, your stomach is going to have to like really churn it and chop it up if you didn't chew it as well, as opposed to just drinking the apple juice and like the calories, the sugar is instantly available, right?
exactly, exactly. And then some of those calories are going to get lowered down because you can't absorb all the calories out of the apple. I'm going to use the apple as an example. We can use any high fiber food. So some of those calories are going to end up not being digested in the beginning of the gut in the duodenum, and they're going to get down to the ileum. So they'll start activating a part of the gut called the ileal brake, where essentially once the ileum senses nutrition, it slows down the entire gut. It's almost like we are full. We need time to absorb. So that ileal brake is like another satiety mechanism being activated, that I'm fuller for longer because the nutrition is getting down to the ileum. And then once you get more nutrition down into the colon, because you need nutrition in the colon for the gut microbiome, they'll start eating it up and they'll start producing things like short chain amino acids. And those appear to help as a satiety mechanism. And then you'll also start burning more calories just through the depositing the calories. The microbiome itself in the gut probably burns as many calories as like a kidney does. So it's like you have a new organ that's being built. So towards the end of our diet, we will start recommending foods that we kind of almost give like a prescription. So we usually recommend that they have like at least one of each one of these foods a day, and then after that, they can kind of eat what they want to do. So usually it's a legume, a whole grain, fruits, something fermented, something green and
And
crunchy.
these are to rebuild your microbiome, right? You told me about this before. Go through those real quick, one by one so we can, kind of document it and put it in there.
Sure. So we want to ferment it. So every day we want a whole grain. It could be like brown rice. It could be whole grain, whole wheat bread. But usually you got to make it on your own. It can't be something you buy from the store because most of those are actually ultra processed. It can be sourdough bread. It can be bulgur. It could be all the like bulgur, rye. I'm trying to think of other ones like
So
millet.
like tabbouleh would be a good one.
The blue is a good. That one would hit too because you would hit
With
the
almost everything, right? Except the
yeah.
beans, maybe.
Right, and this is very, very prevalent in Mediterranean diets. Like we forget how much like couscous is and stuff, or bulgur, and then just they'll mix it with everything. Even like if you have like kibbeh,
The chickpeas, the sesame seeds, all that
yeah,
stuff.
definitely. So that's a whole grain. We want a little bit of that. It doesn't have to be a lot, but just a little bit of that every day. We want one legume per day. So that essentially means that you're going to have black beans, kidney beans, chickpeas, and anything like that. Peas once a day. And then we want a fermented food every day. So that's going to be something like I usually will have kefir. You can have maybe a little bit of Greek yogurt. It can be anything else that's fermented, kombucha, sauerkraut, as long as it's not in vinegar, 'cause vinegar will kill the microbiome, the microbes. So you want it something that's not in vinegar and usually has to be refrigerated in order for it to be not in vinegar. Because it's on the shelf, it usually has vinegar in it, and that usually killed the good bacteria. We want a crunchy and a leafy vegetable if possible. So tabbouleh is great because it hits like two of those already. And then we want
You could throw some chickpeas in it too.
yeah, then it's perfect. Yeah. And then typically a dark chocolate and then maybe a little bit apple cider vinegar because there is a little bit of kind of sugar regulation with the apple cider vinegar. And there are some studies on like dippers, essentially people who could become like transient, like this very low hypoglycemia. They end up eating more calories at the end of the day. So we want to make sure that the blood sugar levels are essentially well regulated in a sense. So if you eat that every single day, and then we want some fruit. So usually berries, some type of fruit per day. So if you eat all of that in a day, you're usually pretty full, and you're not really having crazy cravings because you had something sweet, you had something with fat, you had something with fiber, and then just eat whatever you want, kind of on top of that within reasonable reach, and then usually you're pretty good. And you'll if you can eat that sustain, if you can eat everything I just mentioned and sustain it, you're gonna find that you're not really craving that much stuff, and your hunger's way better regulated. Because essentially you've taken all the vitamins and all the fiber and everything your body really needs through nutrition. And everything I mentioned is pretty much the part of every single ethnic diet that aren't dealing with obesity. So that everything I mentioned is Mediterranean,
The blue
like
zones, basically.
exactly like I think you come from a Mediterranean background as well, but like for breakfast, it'd be very easy to have something with chickpeas or fava beans, for example, a whole grain, and then there might be a little bit of eggs. There would be a lebna, which is like a kefir cheese. So you've already hit the fermented and you've already hit the legumes by the morning. By the afternoon, you're probably having some salad like a fettuccine or tabbouleh, like you had mentioned, with a whole grain. And then usually dinner is going to be some type of protein or rice. So you mostly hit
Yeah,
almost
true.
everything.
And some
With the-
fruits at the end of it for dessert, sliced
yeah,
up apples, oranges, whatever.
exactly.
Absolutely.
So you essentially hit all those. And if you keep doing that day in day out, you're usually pretty satisfied. And then if you crave pizza afterwards,
That's the thing. Like the people, like I always tell my patients, if you eat higher volume food, like imagine eating a pound of broccoli,
yeah,
right? Or a bucket of broccoli, let's just say, just go crazy. A
right,
huge bucket of broccoli. It is a lot of broccoli, and you will feel stuffed. And the amount of calories that's in it, though, is not that much.
right,
1 tablespoon of olive oil will be the same amount of calories, right? So if you eat higher, if you're hungry towards the end of the day, or let's say you're trying to control calories, you eat higher volume, low calorie food, like huge amounts of like lettuce, celery, all these things we're talking about, you'll end up stuffing yourself with things that don't cost that much in terms of calories.
mhm,
And it's a huge strategy. Like a lot of my patients are like, well, I get really hungry at night and I can't fall asleep because I'm hungry. I'm like, you know what? Go eat a pickle. It's like 7 calories, but you feel something salty, crunchy, watery, and you feel like it fills you, a big, huge pickle or whatever, like 7, 8 calories.
right.
So those kind of strategies definitely work. One thing I wanted to ask you about is there's been a lot of research on the different people's gut microbiomes where an obese person, their intestinal flora absorbs certain calories and certain foods differently than like a thin person. They might have a different intestinal flora
Mhm.
where they may not absorb as many calories. I don't know if they've tried like fecal microbiome transplants or any of that stuff, but do you know of anything on that front?
Yeah, there's like I forget the bacteria off the top of my head, like Firmicutes. I think there's like different ratios that they found with microbiome studies. I know Tim Spector has done studies where they found different microbiome signatures, and they can kind of tell what foods the person's eating or not eating based on their signatures. So they can tell, for example, if a person's a coffee drinker or not a coffee drinker based on the microbiome. But the more you look into it, the more and more you realize that you have no alternative but to eat the sources of food. That you can't really take probiotics to compensate because most of the probiotics are just lactobacillus and bifido, which are not they're aerobic, and most of the bacteria we're dealing with are anaerobes. So the aerobic bacteria, they're not horrible, but you can just have Greek yogurt or kefir, and then you're good in terms of getting the bifido and the lactobacillus. Even if you have lactose intolerance, you'll start tolerating lactose better if you have kefir because then those bacteria will start consuming the lactose instead of you just farting it all day. So we know that microbiome is important. We know it's important for food allergies. We know the absorption of foods is abnormal in patients with food allergies and how their body deals with the food allergies. We know the microbiome is important with Crohn's disease or also with colitis. So it definitely is effective in every single element. We know people who exercise have different microbiomes than those who don't exercise, but it's usually just another emphasis on the lifestyle measures and how they're going to improve your health, as opposed to doing something to try to manipulate the microbiome on your own to try to get yourself to lose weight. Because I haven't found that help at all. Everybody takes probiotics. I've never found that.
Yeah, I don't think it's like a huge difference, and I think it's probably an evolving field.
Mhm.
I think we'll know more about it, I'm sure, down the road. But for now, obviously what we're talking about in terms of weight loss, doing the basics like what we're talking about is, and if you need medicine, obviously have a doctor help you with that.
Right.
One thing that always people bring up is that they lose lean body mass when they're on these GLP-1s, and the public thinks it's like this huge scare. Oh my God, these GLP-1s are causing you to lose muscle. My like the science and research, it's not the medication, it's the quick weight loss.
Mhm.
Anytime somebody loses weight quickly, about 20 to 25-ish% or up to even 30% of the weight you lost is going to be lean body mass. That doesn't necessarily always mean muscle. It's like organs, water, glycogen, even bone mineral density, whatever.
Right.
You're losing that more because of the quick weight loss. If that's why we always tell people the slower you lose weight, if you maintain protein intake and you lift weights, you're less likely to lose muscle. Have you noticed a huge controversy about that? Are people talking about that? Does that seem to be an issue?
Um, because we're dealing in
I
a patient, a lot of the patients are novices when it comes to weightlifting. So any weightlifting, usually they notice muscle gain or at least strength gain. So they don't really relate it. But when we do body scans on them, we do find that they have lost lean mass. But like you said, it's a lot. It could be water weight. We're not noticing like huge decreases in strength, but like I said, they're not like Olympic like Olympic lifters that they're going to be very cognizant of the decrease in strength. But typically, I think that sometimes we confuse. what's necessary for the 99% of the public versus like an athlete. So if I was competing in like in jujitsu championships, any like 0.001 second difference is going to be championship versus there's a very small margin between first and second place. So following that person's advice on what I should do to my day-to-day health when I have kids and I have a job and I'm not doing this 24/7, I think it becomes very difficult to do. So I don't like to focus on that too much. I have never had anybody say like you've lost weight throughout your life, right? You've gained and lost. And have you
Yeah.
ever really worried about your strength gains?
No, not at all. I think a lot of it is just overhyped sensationalism. I know like Peter Attia got on the news on CNBC or MSNBC, one of these news shows, like, oh my God, 30% of the weight loss is coming from lean body mass. Well, listen, people are losing weight quickly. That's what happens when you lose weight quickly. And like you said, these are not like athletes that are trying to run around and like win shows or medals or,
Right.
Olympic,
But
sports. These are
if
like
you want
everyday people that are just trying to lose some weight so they're a little more functional.
right. So when they like emphasize like taking like the mTOR inhibitors for increased longevity or taking metformin for increased longevity, how does mTOR inhibition, doesn't that decrease hypertrophy? Doesn't that decrease muscle mass? So I think it is like if you want to live to 100, you have to be metabolically healthy, and you're going to be more metabolically healthy even with 30% of lean weight loss, depending on where you are. So definitely, if you're 15% body fat and you're lifting weights, you have to be cognizant of the muscle. You're sacrificing muscle for fat loss if you're trying to get
Oh,
from body
absolutely.
weight to 10%.
The muscle when like bodybuilders, for example, when you bulk or you're in a bulking season, you'll put on a lot of muscle and some fat. When you shave off the fat, you will lose some of that muscle. Now the idea is to try not to lose as much. You want to mitigate it by eating more protein, still lifting weights. Your lifts will get weaker actually. Your especially bench press. Bench press, the strength and the amount you can do decreases the most of all the lifts. I've noticed that myself personally too, but the
Yeah,
studies have shown that. But obviously, most of our patients are not trying to become like bodybuilders. Now, we definitely don't want them to lose muscle, and we want them to mitigate it as much as possible because sarcopenia is a huge, cause
yeah.
of debility. Um,
But they're
but
going to
either way,
regain it once they go into a calorie maintenance. So that's the other issue.
yeah,
Is I don't.
exactly. As long as they keep, doing the lifting and the activity
Yeah,
that they now do and all that stuff. In
right.
terms of the medications, again, sorry to circle back a little bit. You said there might be a pill coming out for Ozempic, right? Because the current pill form of it is called Rybelsus. It's a super low dose. It's like 3, 7, 14. It's twice a day or once a day, whatever it is. I've used it a few times on people. There's like almost no weight loss. Um, you said there might be a 50 milligram pill coming out, right?
Yeah,
And
there
that
was a
seems
study done on much higher doses. Unfortunately, it is a peptide. A peptide means it's a protein, so your body will break it down in the stomach acid. Therefore, it won't get absorbed to the system. So you have to do
right.
way higher doses. I think it was like 40 milligrams, and it did cause significant weight loss. And that will be that would probably be helpful with the shortage, and hopefully they can make that cheaper than the current injection because they don't have to worry about the price of the injector and all that other good stuff.
Right.
So that's one option. And then there's I'm gonna mess up the name. It's like olorfruon. There's another non-peptide keto version. So it has better bioavailability and it causes significant weight loss. So we're probably having a bunch of medications that are gonna cause 15% weight loss. The one caveat with the medications, I think there's a couple caveats. One is we need these medications for patients who are currently to need them to become healthier and live healthier lives. But we still have this obesity crisis that's happening, and we still haven't really found a way to deal with the obesity crisis. So what right now, if you're born today, there's like a 65% chance you're going to be obese by the age of 30. So we don't want to put all of these people, dedicate their lives to medication in the future. We want to figure out what is causing this crisis and trying to find applicable ways. And for the most part, it is slightly poverty driven because ultra processed foods are very convenient. They're very cheap. You can eat healthy cheaply, but it's expensive to prepare the food because preparing the food might take an hour or two. So if you're working 2 shifts, back to back jobs, coming home, you might just be too tired to sit down and start cooking rice and chicken and stuff like that. So that's one element of like the difficulty with the medication. And
But also part of it is obviously choices. Like you can go to Chipotle almost every day and get a bowl of white rice and chicken for like a few bucks, right? So I think obviously a lot of it is education around that too. Like, you can go eat out and still not overconsume calories or make it healthier, right? I mean, we know that. And I try to teach my patients that as much as possible. Like, you don't have to go to Burger King and get two double whoppers and two huge fries, right? You could get away with just one if you
Right.
wanted to,
Right. I mean,
or
we saw
buy a Whopper and cut it in half.
right.
Save the other one for tomorrow. It's not even a dollar or whatever the dollar
Exactly,
menu
yeah.
is.
A lot of our patients, they find it kind of as a revelation when we tell them, like, "Listen, you can just go to the grocery store to get lunch. You can just go buy a packet of strawberries, wash them, and just down that. You'll be really full and you're
On
good."
some fire Greek yogurt, 0%. That's like protein, fruit, tastes good. It's like eating ice cream with berries on it almost.
Exactly, exactly. I mean, I typically right now that I'm trying to cut, my typical lunch will be around noon, so I won't eat until noon. I have coffee in the morning, and then around noon, I will have literally those microwavable rice packets. I will microwave that, and then I'll split it in half. I'll eat half of that one day, half of it the other, and then I just mix it with half a can of beans.
There you go.
Yeah, and then for taste,
A
I
little
just
bit of protein, a little bit of carb. Well, mostly carb, but a little bit of protein.
yeah, and then I just down a protein shake with that. Now I'm good for and then about 2 that gives me like my legumes, my whole grain, and my protein, like the protein shake. And then like within 2 hours, I'll consume like a Greek yogurt, a little bit of kefir on top. I'll put in a little bit of nuts, a little bit of seeds, and then I'll fill it up with berries. And then that got my fermented foods, that got my fruits in, that's got my nuts in, my berries in. And then for dinner, I'll just have a light salad and then whatever's available. And then usually by then I have a very hard time overeating because I'm pretty full from those meals. I
Yeah.
got all of my checklist in and I'm really not craving anything else.
Now, do you have a? Sorry to change gears again. Do you have a preference between Manjaro versus Ozempic, or do you just pick whatever the insurance will cover?
I unfortunately I have to lean towards what the insurance will cover. So if they're
Yeah,
sometimes they have a
same.
hemoglobin equivalency of like 6.5 and the benominant formin, it's a little bit of like, yes, hopefully they'll cover Monjaro. But Monjaro is the better of the two because of the deepy side effects of the nausea. It's better tolerated than the Ozempic is.
And it causes a little more weight loss.
Definitely, yeah. So we do see better
But
weight
I
loss.
found that, like, with gastric bypass, that's always been like the gold standard, the Roux and Y gastric bypass. People lose about 30% body weight.
Yeah.
With Ozempic, phentermine, metformin together, man, we are getting close. Like
Yeah.
that 3 pill or a 2 pill, one injection combination, man. I mean, it is like, I mean, we might not ever need gastric bypass again. Who knows down the future? Now, obviously, not everybody responds the same to
Yeah.
these medications, but for what I'm seeing, like on the bell curve, the vast majority of the people kind of being in the middle, that three medication combination can cause massive amounts of weight loss depending on what order you put them on it and how you do it and all that. So I
I'm seeing
think
the
we're very
bariatric surgeons
close.
are I'm seeing the bariatric surgeons are doing more uh of the meds than they're doing surgeries now.
That might be smart, but the other thing I'm seeing, they'll do a sleeve gastrectomy first, and then if that doesn't work, then they switch you to a Roux and Y later. So they get two surgeries out of one
Yeah.
from people. So you're almost like double dipping.
Yeah.
But yeah, doing medications is obviously smarter. Like one time I got sent a patient, I think it's this guy actually. They sent him to me. They're like, you need to clear him for surgery. He's 472 pounds. Clear him for gastric bypass surgery, but we're not gonna do the surgery till till his number starts with a three, till he's like 300 something. So I
Mhm.
was like, I got you, bro. I was
Oh,
like, I'll get you down into the 300s. So he comes back. This was like April or May. He comes back a few months later. He's like, Doc, I'm 326. He's like literally dropped like 130 pounds in like a matter of months. I was like, damn, 326. All right, well, you're probably good for gastric bypass now. He's like, no. He's like, if this is working, I'm just gonna stick with it. I'm
that's
like,
amazing.
well, okay, keep
Yeah.
at it. Why not? That makes sense. So
Yeah.
he was on that the three, the metformin, phentermine, and Ozempic, and he's just dropping weight like crazy. We're giving him his life back. He's like, he goes, he goes, he goes. I can actually see my penis now, which we don't think of as something. And I'm not making fun of the guy. Hey,
Yeah.
if you're ever listening to this, I'm really not. But the whole funny thing is he was sent to me initially to clear him for gastric bypass, but they're not going to do it till he's under 400, till his
Yeah.
number starts with a three. We got him down to almost a two.
Yeah.
But he said something really funny. He's the one to start laughing, actually, not me. I don't laugh at
We
my
we uh
patients.
we underestimate how much is life changing for people to
Oh, absolutely.
like I've never really like I treat allergies all the time. I have people with life threatening food allergies. People are like thankful when we get their asthma under control, but it's nothing like when because it really changes their whole life. It changes their confidence, it changes the clothes that they get to buy, the fashion that they get to do, and it makes you just feel better all day. Like joints don't hurt as bad when they get up in the morning. They have more energy. They can play with their kids more. So really, it really is life changing. I sympathize with the bias because there is this like element of like people are really desperate. I mean, that's why there's all these fake gurus. Like in the allergy space, there isn't really that much fake gurus. I mean, a lot of people say misinformation about allergy space, but like people aren't desperate to kind of believe in a solution, but in weight loss they are, because they've been trying really hard and it's been occupying a good amount of their mental space, and people have been like it kind of affects their identity overall, and to have that identity shape really changes their life. So it's very rewarding when it works out. But the unfortunate part is that there's so many factors that might be difficult for us to tackle on an
No,
individual.
absolutely. But I love how the field is evolving. I
Yeah,
mean, we're going from, man, we have medications, but they barely work. This is like, 15, 20 years ago. And then now we got medications that I can force you to lose 100 pounds in a few months if I wanted
yeah,
to.
right.
So it's
Um,
fantastic.
Yeah, the main thing for us has just been like trying to figure out where do we fit it in if we're trying to get people off. And I think that because a lot of the obesity space is kind of focused on remaining on the medications indefinitely. And for us, we do believe kind of in a Kickstarter. But usually that if we can try to get them to change the habits, kind of with like an empty canvas with the medications kind of clear out their mind so they can kind of think clearly about how they're going to do this practically, and then try to get them off if we can. Now, not everybody gets off. Some people have diabetes, some people are doing really well on it and they can't change their lifestyle. So we don't take everyone off. We don't do it forcefully. We want to give them that option.
Well,
So
in Ohio, we were forced to take them off. Like it used to be in Ohio before all these medications. You could put somebody on phentermine, but only for 3 months, and then
mhm,
they had to come off for six, and then they can go back on again for 3 months. That was the rules. They changed it recently, so
oh,
we were kind of forced to do that. We'd put people on phentermine. Some people lose 20, 30 pounds, and then they kind of hold steady, wait 6 months, and try to go back on. That was the rules. Some people gained some weight back, some people gained a lot back, some people just were like, "Ah, cool, I'm good."
yeah,
So I think a lot of that kind of just depends on the person. But I think a lot of it is like a lot of my patients tell me, I did not realize how much I was actually eating. Like I think that plays a huge role. It almost force teaches you what you're supposed to be eating or how much, or how to deal with that food, or like what you actually need for your needs.
yeah.
So I think that makes a huge difference too, just the habits and the understanding, the education you get from it.
Definitely. There's a huge element that's a little bit why I'm a little bit nervous with all of the online programs that exist, is because if I have people who are already on like 2 milligrams of Ozempic, if they haven't lost weight, and they come and see us and they're like, "Hey, can we start like the coaching program and the diet and like the training now?" We have a way harder time with them. And then typically if somebody's just on 1 milligram, we are able to do a lot better with them if they start with us in the beginning. We just realize that the coaching element of starting the medication with coaching is really beneficial. But if you just and like with fentanyl, we used to see the medication thrown out all the time. People just throw the medication at them. They wouldn't lose weight. They would lose hope. They would lose focus on it. And you would ask them, they would say that, yeah, my appetite did go down, but they didn't know what to do with that. They didn't have so we really like the way we usually tell people is we're going to do what you've already known that you should do, but now it's going to be easier to sustain. And then after 4 or 5 months, you're going to find a lot easier to come off of it, because you're going to have developed all these different habits and a new identity around this weight loss. Because people are motivated to lose weight, but they're really motivated to maintain once they've already lost it, once they see how it changes their life.
One thing I have noticed, and you probably have too, is there's a lot of these random doctors. They're like, "Hey, I'm an obesity physician now." Like, there's these ER doctors that do telemedicine, obesity, and like a gynecologist that does telemedicine, or even like obesity. Like, dude, what are you doing? You don't even know the first thing about it. Like, where are you? You read a paper, or like you watched a video about it, and you're like an obesity doctor now. Like, you're putting people on random medications. You have no idea what they do, how they work, what to do with them. You don't, give them the support. Like we bring weight loss patients in almost every month. We talk to them. We look at their food logs. Like I look at their MyFitnessPal. I help them set up MyFitnessPal a lot of times before, we start with meds even. But a lot of these doctors are just throwing meds at people, like you said. And they're just like, go, yay, wait, lose weight, come back, see you on video. Like it's just insane. Like I'm licensed in 18 states. Like why? What do you mean
Right.
you're licensed in 18 states? Like you're
Yeah.
seeing people in Atlanta, Georgia when you live in California? Like just because you can shoot a script electronically doesn't mean you're doing the patient a service. Well,
Right.
they're paying me $100 a visit. Like I know that, I get it. Sounds a little bit unethical. That sounds insane.
Yeah, a lot of
But
these are just
I don't know.
text-based too, like, they're just texting back and forth, getting the medication, and then that's essentially it, and that's why, like, it gets confusing. So definitely, I feel like if you're gonna try the weight loss, you're gonna try the medications, really invest in, like, an ecosystem where they're really gonna kind of emphasize the weight loss and emphasize different aspects of the weight loss and trying to get your health kinda together. Because honestly, you might hit roadblocks. Like if I was doing an online doctor and they didn't know how to manage my sleep apnea, or they if I was diagnosed with NASH and I wasn't sent for like ultrasound or have that like monitored, then what are you losing weight for? You're just losing a number. Like you need to monitor those other things because you're losing weight in the end to live longer, and we want to make sure that that's occurring essentially.
Yeah, and I know that a lot of the studies, and I talk about a lot of these behavioral weight modification programs, BWMPs or whatever they're called, if they took patients and they added just a behavioral weight modification program, well, you meet with a nutritionist once a week and a dietitian or whatever it is, as opposed to just the person's like, go diet and exercise, here's what you should do. In 12 weeks, the ones that also had the nutritionist meetings and the counseling and the support group and all of that, the more behavioral weight loss modification programs you're involved in, the more weight you lost, the more sustainable it was, and the more you're able to do it on your own after the study was over, as opposed to these people are like, here's what you should eat, see you later, here's the exercise program, see you in 12 weeks. Those people had almost such low success rates compared to the ones that actually had the support ecosystem like you're talking about, where they had people with them along the way to help them with all of that. So that makes a humongous difference. And
Definitely.
same thing with like quitting smoking, same thing with like, whatever it is you're trying to do. If your spouse supports you, you're in a support group, your people around you are helping you, all of that makes a huge, huge difference. Like accountability partners, accountability groups, whatever you want to call it. And it sounds like that's the setup that you guys have down there. Um, so I think that definitely helps. How do people get a hold of you? I'll put it all in the show notes, obviously, too. You're in which suburb in Dallas?
I'm in Irving, which is in the
Irving. So that's not really a suburb. That's its own city,
it's its own city, yeah, and then Arlington. Those are the two cities.
Arlington.
Yeah,
And
yeah.
how do people get a hold of you? Maybe send me that stuff and I'll put it in there.
Yeah, so our website is we're Cure Allergy Clinic and Cure Weight Loss Clinic, so you can just go to cureweightlossclinic.com and then,
Cure, just CURE,
CURE, yep, weight
how
loss
you would imagine it. Okay.
exactly, yep,
I'll
and,
put that up there.
yeah, and then, you can just search my name, Dr. Imam, DrImamOfficial.com, and then or, follow me on TikTok, I'm Doctor Food Allergy.
Yeah, you know what's funny is we met on TikTok. People don't know this backstory. Turns out we've actually like I was your counselor in a youth camp at one point, and
yeah, there
I
was like a
motivated you and inspired you to become a doctor.
yeah, yeah, yeah. You were like all into paintball, so you were like my counselor, and you were like this guy. You were just starting med school, and you
That's
were telling
hilarious.
everybody you were going to become a surgeon, I think. And then,
I did. That's exactly what I wanted to be. I wanted to be a surgeon because my dad's a surgeon. I thought I would just take over his practice and join him. That's literally totally true. I don't remember any of this, but
yeah, and then I remember that you had a paintball website. I think it was called paintball.com, and you had just told me like, yo, I just sold paintball.com, and you're like the first time to paintball. I was like, oh god, this guy's so cool. I'm going to become a doctor too. And that was it. Yeah. And then there was like
that
other
is
people who
so
motivated me
super
too.
interesting.
But yeah, and then like next time and then I think I was in medical school and I found out that you had just become a cardiologist and you had started a blog and you had done rotations at Henry Ford and I trained at Henry Ford. And I was watching
Yeah,
your videos on how to read EKGs. And I was like, dang, this is the best video on how to read EKGs when I was in medical school. You were teaching a Midwestern class on how to read EKGs. Yeah. And then I
right.
popped up on TikTok and that's when I reached out to you.
Dude, that is so cool. That is really
Yeah.
cool.
So you're
That's
based off of,
fascinating.
you're out of Ohio area, Toledo or?
Yeah, I'm based out of Northwest Ohio. Toledo is my main hub. I go out to some of the, smaller towns like Wauseon, Napoleon, Defiance.
Okay.
But yeah, no, I'm like big on almost all social media platforms. If you type in Dr. Alo almost anywhere, you will find me.
Okay, awesome. Yeah, you've gotten it. Awesome. So you're doing great work and definitely I think I started to like a stan again because of you. So that's
Hey, maybe I've saved and or prolonged your life.
yeah,
I
yeah,
get that comment a lot. I get a lot of DMs. People are like, they don't put it in. Sometimes they put it in the comments, but
yeah.
they'll give me a DM like, "Hey, doc, my cholesterol is because of you. I got back on a statin. Now my LDL is only like 60 or 70. Like, thank God you saved my life. I don't know. I was crazy. I was following these gurus and these people, these eat the saturated fat crowd, and I whatever. They're like, I didn't know. I didn't realize it, but I was dying. It's
Yeah.
kind of funny.
Yeah, I know it's crazy. It's
I guess it's making a huge difference. I mean, I figure if I can save one life, even just by posting all these millions of videos, if I can just save one life, is worth it in the end,
yeah,
right?
definitely. I think what's crazy is that being a doctor is definitely like a lucrative profession, but selling supplements is way more lucrative.
Oh, absolutely. If I were to like put a supplement out there, holy smokes, I'd be a billionaire.
Yeah, exactly.
I
So
mean,
when people are promoting
multiple
supplements, it's like
multiple time billionaire.
yeah. So when people are putting out supplements and trying to sell that, that's a huge red flag. I mean, I could recommend supplements like, but hey, you should take vitamin D, but all those supplements already exist out there. If I open up my own brand, and I start promoting that, you can't trust anything I say. Everything's gonna be biased towards those
Yeah, it's
supplements.
super unethical, I think, for a doctor who's a practicing doctor to like pitch their own brand of supplements. That's nuts.
Yeah,
Like, I think there's a way to sell supplements ethically, like for example, like a Lane Norton kind of guy. He sells his own pre-workout and his own like protein powder.
yeah,
Okay, cool. That's not insane. But if I'm like the only way to cure your heart is the special kind of magnesium glycinate or whatever,
right,
glycinate, and I sell my own because I purify it, I get it from the Himalayas and the Silk Road and like make up all this junk about it
exactly.
and like
Yeah.
sell you magnesium citrate or whatever I said earlier, pre-wrapped with my own like
Yeah.
bottle
You had
packaging.
a really interesting interview with, you were debating somebody about LDL, one of the guys who were, like, carnivores and stuff like that, and during the I was watching your debate, and during it, they stopped it, and he started, posting
I know he started pitching his own
he started
supplements. I was
pitching
like,
his
dude, you
supplement, and
can't do that.
he was pitching it about allergies. He's kind of like, "Oh, if I eat desiccated pig kidneys, I'm gonna suddenly cure my, pollen allergy." And it's like, I don't even understand the physics of how this would occur. And, what was interesting is you were debating about LDL, and he was, like, kinda presenting himself as an LDL expert, but then he started pitching this allergy supplement, and I was like, "I'm pretty aware of the allergy space, and I don't think eating, beef kidneys is gonna solve the pollen crisis that's occurring." So,
Not at all.
but yeah, so I think that
I
gives you
mean, and you taught me that even eating local raw honey, like my own honeybees make honey. I take it right out of the hive and eat it. That doesn't even fix your allergies. I did not know
it
that,
helps.
but that at least makes sense mechanistically.
Yeah, it helps. So it will soothe your throat, it might help, but it's not gonna cure your allergies because it doesn't contain the pollen that you're actually allergic to, and it's already been denatured by the time you consume it. It does help because it has its own anti-inflammatory component, just like you would give honey to kids to help with a cough. So you can definitely do honey. I don't wanna, like, negate
No,
it.
no, no. I don't do it for that reason. I just do it because I have bees and it tastes like freaking amazing. That's about all. I thought I have horrible allergies. I get allergy shots, but I thought that it would help. I mean, I didn't notice a huge difference either way, but
Yeah.
I just figured that was like one thing that would help, but I
Have your
guess not.
allergy shots helped?
It seems like it. It's not like a huge difference. Like I've been doing it for like 3 or 4 years now. I don't even can't even
Oh,
keep track.
really?
I don't know that it's made like maybe not. I've accustomed to it slowly, so maybe I don't notice because it's imperceptible.
Yeah.
But I don't notice like a massive difference. But I think it's better because I used to take like Allegra all the time, and I don't take anything now.
Okay,
I
so
used
that
to
is
take
better then.
Allegra and Zyrtec and just keep cycling them. You know,
Yeah,
one kind of loses its efficacy, and I switch to another one, then another one, and but
yeah.
I feel like it's not that bad now. I don't know. It's hard to like really quantify. It's like one of those things like if you can't really measure it, is there? How do you know it's working?
I mean, when we do it, people tell us it's, like, life-changing. That's where we're like, "Oh, it worked really well," and if they don't feel like it's life-changing
I
within a
mean, maybe if they had like super bad allergies, like my allergies were just like nighttime congestion, and I mean you can kind of hear it in my voice. I'm very nasally, and
Mhm.
I have a raspy voice, so maybe that's just normal for me. I'm always like sort of congested in here, and when I fall asleep, or I'm laying down in bed at night, you kind of hear it or feel it the most. Sometimes when I walk outside in the spring, my eyes just start like watering, and my face almost feels like it's swelled up.
Mhm.
So I have like bad allergies. I don't notice that as much anymore. But
Well, that's
definitely there are some days when you walk outside, it's like, watery, drippy eyes, everything.
yeah.
So I don't know. I feel like it probably has gotten better because I don't notice it as much.
Yeah, it's crazy.
But has it been like life changing? Probably not.
Yeah. Well, then off the record, we'll talk about your allergies sometime and see if we can,
Yeah, yeah, we'll do that. We should probably cut this interview.
yeah.
But anyways, people, go follow Dr. Imam. He's on TikTok is his main platform. I'm sure he's on other ones. I'll leave all the links in the description, including his practices for weight loss and allergies. I'm sure there's a lot of people that could use your services. Thank you for what you're doing, man. I appreciate it. I think
Yeah,
a
yeah,
lot of
thank
people
you for
will
having me on, I
learn
really
a lot.
appreciate it. Alright,
Yeah,
take care.
definitely. Take care. Let me find the button to press.